So when provider performance isn't moving, there's a question that usually pops up, and that question is tied to stronger incentive. Maybe the quality bonus isn't meaningful enough. Maybe we need more financial upside tied to the performance. And that could be true, right? But I think there's a much more important question that we fail to ask. And the question is, what exactly does the contract make economically rational for the provider to do? Because an incentive does not operate by itself. It sits inside a contract, and that contract determines who is accountable. That contract determines which members matter or which members count, which measures matter, how performance is calculated, what happens around the thresholds. The contract also ultimately determines how quality changes what the provider earns. Right, so if a performance isn't moving, I wouldn't automatically assume the incentive is too small, because the problem may be how the economics are structured. And that is an important question, because we sometimes treat contracting and quality as two separate conversations. Contracting negotiates the economics. Quality manages the measures. The provider field teams work with the practices. See, those three things eventually collide at the provider level. For today, I want to go upstream, because there's no way we're going to talk about provider performance without understanding the economics behind it. That is the topic for today. Let's get right into it. Let's start with the contract itself. Provider arrangements can create very different relationships between quality and payment. In one contract, quality may create additional upside. You hit the target, you earn a bonus. You miss the target, you simply don't earn an additional payment. In one arrangement, quality may modify a broader payment opportunity. In some value-based arrangement, quality may function as a gate, meaning certain quality requirements have to be met before another economic opportunity becomes available. You see, those are very different structures, and it is worth naming something that doesn't always get stated very clearly. Some arrangements are purely addictive only, upside only. The provider earns more when they hit the target and earns nothing additional when they miss the target. So their baseline revenue stays intact regardless. There are other arrangements that place the provider at a meaningful downside. In those contracts, missing the performance target can reduce the total revenue below what the provider would have earned without the arrangement. Those are not the same economic propositions. And the rest of the contract design, thresholds, the attribution, the risk corridors, they all have to reflect which one the provider is actually inside. So the more useful question isn't simply fee for service versus value-based. It is how much of this provider's economics are actually contingent on quality performance, and how. Is quality a bonus? Is it a modifier? Is quality a gate? Or is it one component of a broader settlement? Because until we understand that, it is difficult to understand what economic signal the contract is actually sending. Now, before we go any further, there is a regulatory boundary that is worth acknowledging here. Medicare Advantage organizations don't have unlimited freedom to design physician incentives however they want. The FPIP, which is the Federal Physician Incentive Plan requirements, prohibits arrangements that directly or indirectly induce physicians or physician groups to reduce or limit medically necessary services to beneficiaries. And certain arrangements that place the physicians or the physician groups at substantial financial risk can trigger additional requirements, including stop-loss protection. So I'm not going to turn this episode into a compliance discussion, but this matters for one reason. Incentive architecture has boundaries. You see, the goal is to create economic alignment around quality and performance without creating inappropriate incentive around necessary care. That is the regulatory frame. Now let's get into the contract design itself. If we are going to financially hold a provider accountable for quality, I think there are three things we need to be very clear. The first thing is, what exactly are they accountable for? The second is, which members count? The third is, how much influence do they actually have over those outcomes? See, the second question is attribution. Attribution can work differently depending on the arrangement: prospective, retrospective, concurrent, and sometimes variation. The methodology matters less, whether the provider understands who counts and when they know it. The specific risk with retrospective attribution is worth naming directly. You see, a provider may invest in quality management for a population that looks materially different at settlement than it did mid-year. And at that point, it is too late to adjust. The provider managed to a population, but the contract settled on a different one. That is not technicality. That is a resource allocation problem that was built into a contract design. Then there is controllability. You see, take a screening measure, for instance. The primary care practice can identify the patient, educate them, place the order, and follow up. But the patient still has to complete the screening, right? So another organization may perform the screening, and the information may have to make its way back. So the question isn't whether the provider controls every part of the outcome. The question is, does the provider have enough meaningful influence over the outcome to justify the accountability we've placed on them? You see, plan importance and provider controllability are not the same thing. A measure can be extremely important to the health plan and still be a poor candidate for provider level financial accountability if the provider has limited ability to influence it. See, that is a critical contract design test. Now, let's talk about thresholds. A threshold isn't just a performance target. It is an economic mechanism. So imagine we have two practices under the same contract. The threshold is 80%. Practice A has 78, right? Practice B is at 62. It's the same 80% target, the same potential incentive, but economically, those practices are in very different positions. For practice A, the target may feel attainable. On the other hand, for practice B, the investment required to reach it may look very different. So now think about a binary arrangement. You reach the threshold, earn the payment. You miss it, you don't. That creates what we can think of as the cliff effect. Just below the threshold, additional improvements may carry substantial financial or economic value. Once the threshold is safely achieved, the marginal financial value of further improvement may decline sharply depending on the contract itself. And far below the threshold, the provider may look at the required investment and question whether the return is realistically attainable. See, that is why threshold design matters. Is the threshold a single threshold? Is it multiple tiers? Is it improvement plus attainment? Is it partial credit? Each creates a different economic signal. So I'm not saying one structure is universally better. What I'm saying is that understand the behavior your structure makes economically rational. Because thresholds don't just determine the payments, they influence where the provider allocates the resources. There's another issue here that deserves more attention. A health plan may have certain measures that are especially important to its quality strategy, and that is reasonable. But it doesn't automatically follow that every strategically important plan measure should become a heavily weighted provider incentive, because plan importance and provider controllability are very different things. If the provider has substantial influence over the outcome, financial alignment makes sense. On the other hand, if much of the outcome depends on other parts of the healthcare system, member behavior, health plan operations, factors outside the provider's influence, the contracts need to account for that. So quality and contracting teams have to work together, not simply to ask which measures matters the most to us, but which outcomes should the provider reasonably own and what economics should sit behind that accountability. That is a much better contracting conversation. Now, suppose the contract works exactly as designed, right? The provider organization earns the incentive. Here's my next question. Where does the economic signal go from there? The health plan may contract with a medical group or a health system, but the work required to improve performance may have several levels below that contract. A physician changes the workflow. A practice manager allocates the staff. Care coordinator increases follow-ups. A population health team builds a new process. The payment can land at the organization level while the behavior required to earn it leaves somewhere else. I call that the incentive transmission problem. And this doesn't mean every person doing the work needs individual bonus. The question is whether the organization receiving the incentive translates that economic signal into priorities, resources, and workflows where performance is truly or actually produced. So think about that chain. The contract, the economic incentive, the organizational priority, the operational resources, the practice workflow, the provider behavior, the patient or the member outcome. If that chain breaks anywhere, the contract can look perfectly aligned on paper, while very little changes where the work actually happens. Financial incentives are primarily a motivation and alignment tool. They don't automatically create operational capability. So before increasing an incentive, you need to ask, if I doubled the incentive tomorrow, would the constraints disappear? Would the practice suddenly have more appointments capacity? Would a broken referral workflow start working? Would they suddenly have another coordinator? Would transportation barriers disappear? Would outside clinical information automatically start flowing back? See, probably not. And if doubling the incentive doesn't remove the constraints, then at least part of what we are dealing with isn't an incentive problem. It is a capability problem. That is different investment decision. Maybe the answer is more financial upside, but maybe it's infrastructure, it may be data, it may be care management support, workflow capability. See, the money attached to an outcome doesn't automatically create the machinery required to produce it. There is one more design that doesn't get much more attention, and it's timing. Final contractual settlement can happen well after many of the behaviors that produce the performance. How long depends on the arrangement, the data source, and the settlement methodology. But here's the management principle that matters, regardless of how the contract is structured. A delayed financial settlement doesn't have to mean delayed performance feedback. Those are different things. So you may not be able to calculate the final incentive today, but the provider should still have enough current information visibility to understand where they are, to understand what is moving, what isn't, and where they should act next. Because a contract cannot effectively guide performance if the provider only understands the outcome after the opportunity to influence it had passed. The final payment may lag, but the management signal shouldn't. And then eventually the performance period ends. Now we have to settle the contract. See, this part matters more than people realize. What data determines the final performance? When is performance considered final? How are attribution changes handled at settlement? What happens when additional claims or settlement evidence arrive after the period closes? Is there a true-up process? What is the dispute pathway if the provider disagrees with the calculations? Those details may sound administrative, but they are not. They are part of the economics, because providers need to understand the rules before they even make the investment based on those rules. If the contract says one thing at the beginning of the year and the provider experiences something materially different at reconciliation, you are going to have a trust problem going into the next performance period. Reconciliation isn't just finance cleaning up the numbers. It is the final test of whether the contract operated the way both parties thought it would. So when I look at a provider quality performance, there are 7 questions I want answered. Accountability. What exactly is the provider responsible for? Attribution. Who counts and when does the provider know? Controllability. Can the provider meaningfully influence the outcome? Economics. How does the performance change payment? And what happens above, below, and around the thresholds? Transmission. Does the contract translate into priorities and resources where the work actually happens? Timing. Does the provider receive arrangement signal soon enough to act? The last question is reconciliation. How is final performance determined, settled, and disputed? Those 7 questions connect the contract on paper to performance in the real world. Sometimes we look downstream when provider performance isn't moving. We look at the field team, the quality outreach, the provider, the gap closure strategy. But sometimes the problem started much further downstream in the contract. If accountability isn't clear, if attribution makes it difficult to know who actually counts, if we are holding providers financially responsible for outcomes they have limited ability to influence, if threshold creates the wrong economic signal, if the incentive never translates into resources where the work happens, or if the provider learns how they performed after the opportunity to change has already passed, more outreach isn't going to fix that architecture. And that is the distinction I keep coming back to. Paying for performance and contracting for performance are not the same thing. Paying for performance attaches money to an outcome. Contracting for performance asks a much harder question. Have we designed accountability, attribution, economics, operational capability, feedback, and settlement so that behavior we want can actually make sense for both sides of the contract? That is the work. And before we ask whether the incentive should be bigger, I would ask whether the contract is sending the right signal in the first place. My name is Peter Saad. Thank you for your attention. I will see you in the next episode. Have a good one.